Good morning or good evening, depending on what side of the world you are. My name is Christian Vincent. I'm actually responsible for clinical program at FEops. And it's really my privilege today to have a first experience in the EuroPCR 2021, having a forum combining physicians, experts from China and also from Australia, from Europe, to share their vision about preoperative planning for TAVI case using Venus A devices. So it's really my pleasure and honor today to welcome the faculty that we do have today. We do have Dr. Han from Fuwai Central China Hospital in Zhengzhou in China. So welcome, Dr. Han. We also have Dr. Xiong from West China Hospital, Sichuan University, also in China. So welcome, April. Really glad to see you in this call. We also have the honor to have Professor Peter De Jager from Erasmus Rotterdam in the Netherlands. So welcome, Dr. De Jager, for this nice interaction. And we also have the privilege to have a physician from Australia. So we have Dr. Cameron Doring from Monash Health from Melbourne in Australia. So the methodology of this discussion today, it's first of all, it's a China International Forum. So my level of happiness at the end of this will be to have as much as possible interaction between the speakers, but also with the audience. And that's very important. Please, if you have any questions for the audience, whoever is Dr. Han, Dr. Cameron Doring, Dr. Xiong, or Dr. De Jager, please just put your question in the chat line. I will collect all those questions and I will ask those questions to the speaker during the presentation. So I will be your voice, and I hope we will be able to answer all your questions. So please use the chat line as often as possible. So it's a case-based discussion. That's very important. We will also have, as an interaction, we will also have sometimes quick polls. So a survey just to ask you a few questions. So please just answer those questions. So it will be also very interesting to get a little bit your opinion about the different talk of the day. So by saying that, I wish you a very nice webinar, and I leave now the words to Dr. Doring, who will make the introduction of this webinar. Thank you.
Great, thanks, Chris. If we just go to the next slide, thank you. So as we're very well aware, TAVI is increasingly being used to treat younger, lower risk patients, with a number of randomized trials demonstrating at least equivalent and probably superior clinical outcomes in this patient group when it comes to things like death or disabling stroke. And so it's very likely that in time, TAVI is going to become the dominant therapy for treating the majority of patients with severe symptomatic aortic stenosis, regardless of their baseline risk. But we've got to remember that if TAVI is to go into the true low-risk patients, that the majority of these will have bicuspid aortic valve, and of course this patient cohort has been excluded from all of the randomized trials. And therefore it's very important that the heart team make individualized patient decisions based on perhaps their clinical factors, but perhaps more importantly, their anatomical risk. So I guess the question is, as we go into these low-risk patients, how do we assess anatomical risk, and how do we ensure that we get the best possible outcomes for our patients by ensuring the right valve size is put in at the right implant depth? And I think the answer is, of course, with patient-specific computer simulation. If you could just go to the next slide, please. And so, as you may be aware, this procedure uses a patient's preoperative cardiac CT scan to create a finite element model of the aortic root. And then the aortic wall, the leaflets, and the calcium are given various different tissue properties. And then finite element analysis is performed to simulate the interaction between the transcatheter heart valve and the native anatomy. And then from here, we can undertake additional simulations to look at both paravalvular regurgitation and conduction disturbance. This next slide, thanks. And so here you can see the latest iteration of the FEops product, which is the HEARTguide platform. It's a web-based platform, very interactive, and allows you to look at multiple different valve sizes and multiple different implant depths. You can see how the valve interacts with the native anatomy. You can see how the valve opposes with the anatomy. You can see where paravalvular regurgitation is predicted to occur, and also the severity of that. And finally, you can also examine the conduction disturbance modeling to get a sense of the risk of developing significant conduction delay after the procedure. Next slide, thanks. And the FEops experience is just accelerating. We're nearing 2,700 cases now, and more than 700 in China. The technology is available in a number of jurisdictions throughout the world. And I'd just like to highlight that as of December, if we have any of my Australian colleagues on, we have TGA approval as well in Australia, so you can now use the technology for prospective clinical usage. Next slide, thanks. Carl Schultz, Professor De Jager, and Georgia Roccatella have done significant work on the validation in tricuspid aortic valve. And we've done some more work here in retrospective validation, again with Peter De Jager, looking at the predictive power of the computer simulations. So in the main study, we had 37 patients that had both pre and post-operative CT scans. And we found that the computer simulations can reliably predict the deformation of the transcatheter heart valve within the native anatomy, as well as the development of moderate paravalvular regurgitation. And Jorn Brouwer and Martin Swans have also done some validation of the technology, comparing again the transcatheter heart valve deformation and the development and location of paravalvular regurgitation. And again, there were strong correlations between the simulations and clinical outcomes. Next slide, thanks. So from there, we moved on to our first in-human prospective experience, which was limited to 9 cases. And as you can see, a wide variety of aortic valve anatomy with calcium distribution, different Raphe locations. And we found from our computer simulation that 3 of these patients were predicted to have a poor outcome. And so for 2 of them who were at low risk for surgery, we actually treated them with surgery, and 1 other patient who was at extreme risk for surgery was treated with a balloon expandable device. And for the remaining 6 patients that we treated with self-expanding technology, we really used the simulations to fine-tune our transcatheter heart valve sizing, which is always a topic of discussion within bicuspid, as well as our implant depth. And in fact, 5 of those 6 patients had procedural elements changed because of the computer simulations. Next slide, thanks. We've gone on to treat many more patients. Here you can see our next 10 patients that we presented last year at TCT, again with a wide variety of aortic valve morphology, calcium distribution, and Raphe locations. And again, you can see the very different interactions that the valve has within the anatomy, depending on the Raphe location and the calcium distribution. And I think it just goes to show that bicuspid is not a one-size-fits-all disease. It's a very heterogeneous condition. And so that's why I think the computer technology has an enormous role to play here, perhaps more so than in the tricuspid area. Next slide, thanks. So more recently, we've been doing some work looking to see how the computer simulation can predict long-term outcomes. We know that TAVI is going into these younger, lower risk patients. And so it is critically important for that cohort that we get excellent long-term outcomes. And we know that the technology can predict paravalvular regurgitation. So in this particular study, we demonstrated that the computer simulation can can identify a cohort of patients that are at risk for long-term outcomes. So if the computer simulation predicts you're going to have more than 16 milliliters a second of paravalvular regurgitation, we can see that they have a far worse long-term prognosis. And I think this is a very important consideration as we go into very low risk patients where surgery is still a very viable option. Next slide. I think we're on to the poll. So we've got a poll here to begin with, and we'd like everyone to participate, to just get a sense of what the audience are feeling and usage of the technology is. So the question is, would you consider to use pre-operative planning, computer simulation to support your Venus A intervention? And the options are yes for all cases, yes for selected cases, I don't really perceive the value, or I need some more information. Please don't say I don't really perceive the value. It says I cannot vote. Okay, so we've got a bit of a split there. Some people want to use it for all cases and some for selected cases. Well, certainly my view on the technology is I'd love to use it for all cases, but we live in a world of time and financial and cost constraints. So perhaps some selective patient choice may be helpful. In my own clinical practice, we use it for a number of different scenarios. Certainly for all the bicuspid cases, so adverse anatomy, particularly the bicuspids with calcified raphe. And then for tricuspids, we use it for the very heavily calcified tricuspids, sometimes for patients that are really on the borderline of a transcatheter heart valve sizing algorithm, and a small aortic root. There are also some niche cases where perhaps we might want to see how the frame's going to deform when there is cases of potential coronary occlusion. I think we're going to see an example of that later today. But these are sort of the cases where I use the technology.
Dr. Doling, Christian here. I have a question from the audience.
Yes.
And the question is it right interpretation that's the best, the most important things out of the FEops HEARTguide is to make a risk evaluation before the intervention?
Well, yes, I mean, certainly you can use it to assess a patient risk for developing paravalvular regurgitation. But I see perhaps the main usage moving forward is to really optimize transcatheter heart valve sizing and implant depth. I think we're going to see some examples of today, particularly in the bicuspid patients, where the reviewing of the simulations can be helpful for the operator to decide on a transcatheter heart valve size and implant depth. Particularly with the Venus A technology, which has a higher radial strength than the Medtronic system. I think that a number of bicuspid cases, particularly the heavily calcified bicuspid cases, where we'll see downsizing performed, and I think it's very helpful to have the computer simulations available before you undertake a strategy such as that.
And the second thing is thank you for your vision, Dr. Doling, concerning for which patients the simulation will be optimal. You say all should be optimal. I would also like to have a little bit the opinion of the others. Dr. Han, Dr. Xiong, and Peter de Jager, what is your opinion about for who do you think that the technology should be applied?
Mm-hmm. Perhaps Dr. Han, Dr. Johan.
Hello, sir.
Yes, we hear you.
Yeah, maybe now we know the simple the stenosis aortic valve is maybe easier, but we use to simple aortic regurgitation. We ought to use the FEops.
Okay.
Now we use the simple aortic regurgitation.
Yeah, I think that's really the next space to look at. It's something I've been considering collaborating with people around the world on. If you want to get in touch with me later, but you know, pure native aortic regurgitation is the next frontier for TAVI, and there's certainly been improvements with modern devices, but being able to use the technology for QAR would be really beneficial. So we need to move forward and look at validating the technology in that space.
Dr. Xiong, perhaps, yeah, or you,
yeah.
Dr. Diaga.
There are two things that I would like to add. One is in terms, in relation to the question of the colleague predicting complications. Well, as Cameron elegantly has shown, basically, yes, you can, if you consider PVL conduction as a complication, that I do. But there's something else that I would like to add, is that the HEARTguide also offers you the possibility to predict eventual coronary obstruction. This is a bit forgotten, but this has been published 5-6 years ago. This is about the assessment of the distance of the nodule, calcium nodule on the leaflet in relation to the osteomus of the coronary. And I think, of course, we know that coronary obstruction is not a frequent, on the contrary, a rare complication, but it is possible to use that software for that purpose as well. To follow up with the general question, and I have expressed that before, being exposed now to, let's say, so-called emerging markets, and being in the TAVI field for 16 years now, we started in 2005, given the contacts that I have across the world, I feel sorry that we did not, let's say, had the possibility to access that technology, because we were collaborating with FEops for 10 years in validating the software. And I have expressed that in the ideal world, I believe that we should think, as Cameron also has alluded to, I would take a much more general perspective. If FEops would be capable, and I know they are, of creating a service with a quick return of the response, in which you have an automated analysis and a sizing proposal in association with the regular outcomes, which are now conduction abnormalities and PVL, I believe that we should have a much more liberal approach. The reason why I'm saying that is, as I see how we struggle with sizing. We had a meeting at the end of last year with proctors across the world, and there was one statement: we still do not know how to size. Well, if we want to explore that, we have to use this technology. Remains to be proven to what degree it will impact on outcome, but my hypothesis is this will affect the safety of the treatment. And as a matter of fact, I'm at this moment reviewing a grant proposal for a scientific organization of one of the European member states, and they want to move to patient-centered medicine in TAVI. Well, this is all about the planning. We have to have a more refined planning, and this technology fits into that. That's a bit of general philosophical perspective that I have.
Okay,
thank you very much. Of course, there's the precise TAVI registry being run at the moment, looking at the usage of this technology in complex anatomy, like bicuspids, heavily calcified valves, etc. So I think watch this space to see the results from that. And of course, we had the results of the TAVI guide study presented or published last year, so by Nahid Al-Fakir and obviously Peter De Jager as well. So, I think developing more prospective clinical data is really important for the widespread adoption of this technology.
Okay. Thank you so much. I suggest that we move now for the case review, and the word is for Dr. Han now to present the first case. Thank you.
Okay. Hello, good morning, everyone. Dr. Han. This case is 65 years old, and the LTS score about 4.6%, and the heart function New York Heart Association is grade 3. The mean gradient about 60 millimeters of mercury. with mild aortic regurgitation. You can see the measurements results of remittal. This case is type 1 bicuspid aortic valve, and the annulus, the perimeter about 78 millimeters, and the area is 468 square millimeters. But the case is small centers. We can see the mean diameter about 30 millimeters, and the coronary has in left coronary artery only 7.8 millimeters, right is 12 millimeters, and severe we can see the CT scan is severe calcification and score about 1,164. Next, please. So there are some challenges: bicuspid aortic valve type 1 and high calcifications and small centers. So we use the FEops HEARTguide to simulate. We can see the measurement results. We can see the mean diameter about 24 millimeters. So we can learn from the FEops HEARTguide. It provides patient-specific computer simulations that can help to assess the risk of perivalvular leak and the conduction block. Important different options are simulated. So we can use the Venus A 23, 26, 29, and 32 to simulate at the high position, the medial position, and the low position. It can evaluate the deformation both of the aortic root and the device. Next, please. So we can see picture it to simulate the occlusion of the coronary artery. Pre-operative simulation provides an indication risk of partial conclusion of the coronary. We can see we use Venus A 26 and 29 millimeters valves to simulate at high position. In the low picture, we can see if we use the 29 millimeters valve, it is high risk of partial occlusion at for the left coronary and right coronary artery. Next, please. So this picture is about the contact pressure index and perivalvular leak. We use 23, 26, and 29 valves at high position and medial position to simulate. When the cutoff values were defined, 16 milliliter per second for PVL and 49 and 14% for contact pressure index. We can see the picture. Use the 26 in high position. At high position, only 10% contact pressure index. And here in use the 29. At high position, the contact pressure only 7%. So based on these simulation results, we can see if we use the 26 and 29 millimeters valve at high position to inflate, maybe the best choice. Next, please. So as we know, this case is the mean diameter only about 24 millimeters and severe calcification and high risk about left coronary artery. So our team decided to use the 26 millimeters valve, Venus A valve. About the procedure and the results, we pre-dilatation with 22 millimeters pneumoid balloon. No gradient, while with mild to moderate PVL, and the depth of implantation at non-coronary cusp is 5 millimeters. No conduction block. Next, please. So we can see first we angiography at the root, and then we use the balloon dilatation. Meanwhile, the angiography use no PVL and the coronary artery is normal. Next. So we slowly release the valve at the normal position. Look at the last picture. The results is good. Echo shows only mild leak and the normal and the coronary artery is normal. No conduction block. Okay, thank you.
Thank you so much, Dr. Han, for this really interesting presentation. I propose that we move to the next case, and then after the case presented by Dr. Xiong, we can have a small discussion about that. So I propose we move forward with the case from Sichuan University. Thank you.
Okay, so after hearing, I think that's a prospective case from Dr. Han's team. And we've known that computer simulation might help with procedure planning. Here I present with you two additional cases, which we do retrospectively. But I feel there might be additional learning points of these two cases. So the first case is a 70-year-old male with an SDS score of 8.9%, and he presented with an NYHA class 3 dyspnea to our department. And by TTE, we found the mean transaortic gradient of 45 millimeters of mercury with only trace aortic regurgitation. So here on the right-hand side, you can see a movie showing the aortic root anatomy in motion. And so this is a type 0 bicuspid. On CT, we measured the perimeter of the annulus of 71 millimeters. And both coronary heights are sufficient, and the calcification volume is around 800 square millimeters. Next, please. So in this case, this is a calcified VAV type 0 anatomy. And by doing it with FEops, we plan to, because the computer simulation provides additional insights for heart team decision as it evaluates the interaction between the anatomy and the device. So we selected this case as a retrospective case to understand this interaction. And because simulations can be done by the real anatomy obtained from pre-procedural CT. So it's also helping us to define some key anatomical aspects that may be missed out by reading CT scans. Next. So upon simulation, we can see on the right-hand side, so for this patient, a medium implant of 23 millimeters of the venous valve, A valve, or a medium or medium or high implantation of a 26 millimeters of venous valve would achieve acceptable PVL and PPM results. So we actually analyzed two sizes with different depth of implantation to see like which size would benefit the patient the most. So let's see the actual results, but this is before computer simulation, and we did this case just by analyzing CT scans. Next, please. So we chose the 26 millimeters venous A valve as suggested by the annulus back then. And we pre-dilate with a 18 millimeters of balloon. And after the procedure, the mean transvalvular gradient drops dropped to 9 millimeters of mercury without PVL. And the depth of implantation at the non-coronary cusp is around 10 millimeters, which corresponds to a medium implant depth as suggested on the computer simulation. And the patient experienced a new LBBB, but no first degree AVB. So the patient was discharged without pacemaker implantation. So in this case, what we aim to show is, because there are some emerging new sizing techniques that's taking the intraleaflet structures into considerations. And we've heard methods like supraannular sizing, intercommissural distance, the Casper method or the Lyra plan. So there's plenty of new methods going. Normally, when you are trying to analyzing the intraleaflet region, maybe the new methods would recommend a smaller valve size than suggested by the annulus. So maybe like, especially in new centers with limited volume, then the operators might have doubts whether it would be safe to implant a smaller valve than suggested by the annulus. So so like in this case, the annulus would recommend a 26 millimeters of VenusA valve, but we can also see from if you remember the simulation results on the last slides, we can also achieve a good outcome with a 23 millimeters of VenusA valve if you implant it at a medium height. So if you are having some doubts when sizing your bicuspid case, and you have the computer simulation technique with you by hand, so maybe it would be an add-on to your team when you are facing sizing problems. So like, we know these results are validated, which we can trust. So maybe if we have these, I don't know, like my team might consider downsizing the valve anyways. But this is a retrospective case. So going on to the next case, retrospectively from our center, this is a 69-year-old female with a low risk profile. She also presented with dyspnea to our department, and the mean transaortic gradient was very high, 94 millimeters of mercury. And on CT scan, we saw this was a type 0 bicuspid again. And the annulus, the parameter of the annulus is relatively small, around 62 millimeters. And the right coronary height seemed to be a bit low. And also the patient suffered from multiple calcium deposits. Next, please. So in this case, this is also a calcified bicuspid type 0 anatomy. And also we can appreciate it a short distance from the annulus to the membranous septum, which means, as we all know, which means a higher risk of conduction abnormalities after TAVI. So in this case, we used the technique retrospectively, mainly to look at the contact pressure index to let us fully appreciate the risk of new conduction abnormalities after TAVI. And that's what I would like to show to our audience, how the technique can show you the risk. Next. So we did two sizes with also 3 heights, implant heights. And as we can see on this slide in the box surrounded by the black lines, that's the region of interest. And that's where the conduction system goes underneath. So by rating the contact pressure index from the simulation results, and remember the cutoff is 14%. So if you get a value higher than that in this square surrounded by the black lines, that means you will face a increased risk of conduction abnormalities and also the need for permanent pacemaker after TAVI. So as we can appreciate it on the simulation results, if we are going to choose either a 23 or a 29 valve, we need to implant the valve very high to avoid an increased value of the contact pressure index. Next. But unfortunately, because this is a retrospective case, and for a first generation self-expanding valve, it can be hard for you to control yourself in terms of implantation depth. And we, in the end, implant the valve around 5 millimeters below the non-coronary cusp, which is not a very bad implantation depth, but I would say bad to the patient because she had a very short distance of the membranous septum to the annulus. And remember, the patient was only 65 years old. So I guess if we've had this simulation results, maybe during our heart team discussion, maybe I would say the interventional cardiologist might believe a surgery would be a better choice for the patient. And that's what I would also like to illustrate from this case. And that's also a publication from Dr. Cameron Darling for using computer simulation techniques to guide treating strategies for bicuspid cases. So that's all the 2 retrospective cases from our centers. And I'm happy to have a discussion with you.
Thank you so much, Dr. Xiang. So I really appreciate, it's very interesting to see the specificities of the case that you have in China. So we have roughly something like 8 minutes to go for the webinar. So I propose that now we have a panel discussion about those cases, and probably because it was presented by our friends from China, perhaps Dr. Darling or Dr. Diagre, perhaps you can comment on those cases, giving a bit your perspective or your questions on those cases.
Sure. I mean, if I can discuss the final case first, obviously this patient is at risk for conduction disturbance. They have an anatomical variant where their membranous septum is almost at the annulus. Remembering, of course, that the membranous septum is just a marker for where the AV bundle derives. As a very neat paper by Dr. Kawashima where they do anatomical specimens to demonstrate the variability between where the AV bundle is and where the actual membranous septum is. But this patient is always going to be at high risk for conduction disturbance and is obviously very young. So it's going to be a very difficult case, especially with a first generation TAVI device to get through without having conduction disturbance. And I noticed that the most recent VARC guidelines are getting left bundle branch block as an adverse outcome from TAVI. So we've got to remember that as we go into this low risk patient cohort. Peter Diega has published extensively on the long-term outcomes of patients with left bundle branch block, and it is is something to really start thinking about as we go into these younger, lower risk patients. The other thing I should mention, by the way, is that these were all type 0 cases. That's fairly rare certainly in my clinical practice. And I just wanted to thank the FEops team who've been working really heavily behind the scenes to develop a dedicated type 0 pathway. And it's been really great work to see the engineering team really work on getting a dedicated type 0 pathway so that we can use them in these challenging cases.
Thank you, Dr. Dorling. And you, Professor Diagra?
Well, no, I thank Dr. Johan and Xiong China. I enjoy this very much, in essence, and I'm afraid I'm repeating myself, but what you have presented is not only so nice, but I feel supported by the vexing issue that as of today, we still struggle to size properly. That is the whole main thing here. And I think that both of you have very, very well illustrated this. And I thank you for that. And look, I was thinking when you were presenting, April, that take a sports, an athlete who is going to the Olympic Games. What is he doing? The winning of the Olympics is not in running the contest. It is all in the preparation. And I think, again, both of you have shown, and I'm sorry that I repeat myself, the essence, the essence of proper preparation. I have said that and you in China, you are in an ideal position as with respect you are about, well, you follow what we have done. You are now in a potential pole position to implant proper planning better than what we have done. And I would love you to take that advantage. It will translate into benefit. I agree with Cameron. Perhaps I'm a bit too liberal, that it may well be that it will have a higher value in certain subset of patients. But as I see the work that you do, what you have presented, Dr. Johan, and you, April, it is clear to me that we can have a discussion in every single patient when it comes to sizing. And I was taking a few notes. Your first patient, April, you used the 26, but if I had difficulties in reading the pictures, but I saw that even at 23, it's a bit, I hardly can see read the pictures here, but it appears to me that even you could have an argument in favor of a 23. It's not to say that you have to use a 23, but just for the discussion. And again, with the respect of all the so-called experts, none of us do know how to size. And I would like to capitalize on what you're doing in China and wherever in the world, keep on going, having this discussion. I can't read, but when I glean at the pictures, if I look at the color codes of the contact pressure and the PVL, then I presume the left-handed side is 23 and you use a 26. Yeah? Again, it's not to say that you have to use a 23, but for the sake of the discussion, for the sake of the benefit of the patient, because that patient went home with a bundle branch block, right? Without a pacemaker. But
yes, without pacemaker.
Yeah, but still, you have left, if you could read the number of the PVL, it's a single digit, I believe. It's about the same as a 26, but you have less pressure on the surrounding anatomy. And again, I'm really obsessed about that. And if I go to this patient of Dr. Johan, there was you simulated 3 valves and you saw a reduction in PVL while an increase in contact pressure along the size of the valve. So 29, there's almost no PVL as I can see, but the price to pay is the contact pressure, and you choose a 26. And if Dr. Johan, if you would like to go back to your last picture of the PVL, is that possible? The last cine run there, yeah?
Yeah.
Yeah.
The result, the echo shows the PVL is mild.
Sorry?
That's completely consistent, yeah, with the computer simulator. I think the computer
Yes,
simulator
yes.
was about 10, wasn't it?
The point I'm wanting to make, and as we are here, as we are colleagues, trying to do a better job, if we are honest, critical, and open to one another, you could argue that you would like to have a lesser PVL. Huh? But the price to pay may be the contact pressure. So suppose that this patient would have a pacemaker, then the issue of contact pressure is not an issue anymore. And then it would favor a 29. And again, I thank you really wholeheartedly for what you have presented, because it reflects, if we prepare for the Olympics in a better way, we will translate that into better patient care.
Thank you, Professor De Jager. Wonderful. It's a nice transition. We would like now to launch the last question to the audience based on the cases, just to see in what measure it changed a bit the opinion of the people. We can launch the question now.
You want me to read this, Chris?
Yes, please.
It's a bit difficult for me.
I will do that, Peter.
Yeah.
After those cases discussions, would you consider to use preoperative planning computer simulation support for your Venus A intervention? And the answer may be yes for all the cases, yes for selected cases, no, I don't perceive the value, yes, or I still need more information, just to see if through those cases we make the decision a bit differently. Please vote now. Okay. Okay. Yeah. So 50% they say yes for all the cases, 42 for selected cases. That's a bit of change. And 25% they still need more information.
And what was the response to the first polling? I believe
more people selected for selected cases. I think there's been a movement towards for all cases.
Good. Good.
It's what I would want. I mean, if it was my relative, of course, I would want it.
But it makes sense. Well, again, and please oppose to what I say, huh? Because that's the academic discussion that we need. Again, if you think about it, suppose you have a structure, you just shoot up your CT scan to the cloud and you get the answer the next day. Why wouldn't you use it?
I mean, I must admit, FEops are really investing heavily into the development of AI technology to support the platform. And there's a lot of advances that I'm aware of that's going to be coming out soon that's really going to help speed up some of that process. So what I'd very much say, watch this space, but AI is going to be really helping the FEops platforms of the future.
Yeah, and again, to stimulate our Chinese colleagues, because we are so overloaded with research. But if you think about it, if you set it up properly in your institution, you can capitalize on that academically by assessing the premise that I have, that it will translate into a better procedure planning and thus outcome and valve performance. So you have the opportunity to assess that prospectively if you use that infrastructure.
Super.
No, I completely agree. I mean, that's the dream, isn't it? That the patient gets a CT and it's uploaded, and there's a cloud-based solution, and perhaps combined with the more specific computer simulation coming back in a day or two.
Yeah, and I presume that there will be iterations in the Venus valve. I do understand. I think, Cameron, you don't have experience neither with the Venus valve, but I do understand that it's similar to the other self-expanding technology. Handling the catheter and position it correctly, as we had the opportunity with the Lotus valve, is a bit tricky. So I presume there will be iterations. And that offers again the possibility, if there would be the next generation with a better control of the positioning, combine that with valve size selection, it will enhance or how do we have to put this? It will further stimulate the use of this technology to, well, okay, I can position the valve at that spot, avoiding the contact with the conduction tissue, as in the case of April, when there is a high inferior border of the membranous septum.
Okay, and unfortunately, time is running, and we came to the end, and we are already a few minutes after. But I think that was the value for the good discussion. I really want to thank all the speakers. Thank you, Dr. Han. Thank you, Dr. Xiong. Thank you, Dr. Doring, and thank you a lot also, Professor Diagre. It was a very enthusiastic discussion. I really appreciate it. I think we have learned a lot, at least from my hands. I hope for the audience as well. I really want to thank all the audience, and I wish to all of you a very fantastic PCR 2021, and talk to you later. For those who want to learn more about the FEops, you can always visit us on the FEops website. Enjoy your day and talk to you soon. Bye-bye.
Thank you. Bye-bye.
Great.
Bye.
Thank you, everyone.
Thank you. Bye-bye.